Part 1, Chapter 42, Diseases of the GI Tract. I'd like to thank Elsevier and then Pathophysiology book by McCants, which is an excellent book. It will be in multiple parts to fit on YouTube. Many serotonin, and neurokinin agonist, metoclopramide, which is a very common one, corticosteroids, and then other newer drugs that people use. Can lead to fluid and electrolyte imbalance, acid-base disturbances, hyponatremia, hypokalemia, and all the electrolyte abnormalities, including metabolic alkalosis. Nausea is subjective experience associated with a number of conditions. Common symptoms are hypersalivation, tachycardia, retching, projectile vomiting. Sometimes spontaneous vomiting does not follow nausea or retching. One of the most common problems you deal with in primary care is constipation, infrequent or difficulty in defecation, normal 2 to 3 bowel movements per week, and as many as 3 per day or 4 per day, depending on the person. So the pathophysiology is normal transient function, constipation, normal rate of stool passages, but the difficulty of stool evacuation from low residue diet, sometimes low fluid intake, slow transit constipation, impaired colonic motility. Then you can have pelvic floor dysfunction and secondary from actual disease processes, diet, and medication. Of course, narcotics can cause that, right? Because of opioid-induced constipation. Clinical manifestations of the following will occur for at least 3 months. Straining and defecation, at least 25% of the time, hard monthly stools, sensation of incomplete emptying, fewer than 3 bowel movements per week. Fecal impaction, hard, dry stool, retained rectum. Many times, the only way to deal with this with dry enemas is to disinfect it manually, which is more common in elderly patients, but sometimes people who are on narcotics. Treatment, bowel retraining, moderate exercise, increased fluid intake, fiber intake. Enemas should not be used habitually. And then dysadnergic defecation by biofrequent drugs such as 5-HT2/4 antagonist, and there's some other stool softeners. And I'm a big fan of using milk and magnesium, 1 tablespoon every other night before bed, and to make sure people are hydrated, and usually that's enough to help them start to move their bowels after you get them. Diarrhea is an increased frequency of bowel movements, more than 3 times a day, increased fluid, increased volume, fluidity, and weight of feces. In other words, it's not being dehydrated adequately. There are 3 major types of diarrhea. Osmotic diarrhea is non-absorbed substance in the intestine, water, lumen, osmosis, causes large volume diarrhea. Secretory is a form of large volume diarrhea caused by excessive mucosal secretion. And motility, excessive motility, decreased transit time. The mucosal surface. So clinical manifestations of dehydration, electrolyte imbalance, hypokalemia, hyponatremia, metabolic acidosis, and weight loss. The reason why you have metabolic acidosis, you have to think about this, but you remember that if you lose your bicarbonate, then you become acidotic. So when you have diarrhea, you frequently lose a lot of bicarbonate because of the rapid transit time. Not enough time to reabsorb it in the kidney. So treatment, restore fluids, electrolyte imbalance, medications, amotility, drugs like Lomotil, mild diarrhea, natural brand, and Ficillin, which is a natural roughage. C. difficile associated diarrhea, probiotics, and fecal transplant. We have a new article that I'll talk about next time we have class, where there's a big problem in the FDA now deciding whether this is going to be considered a new drug or a transplant. if it's a new drug, then the companies could patent it and monopolize it. So systemic manifestations of diarrhea, the manifestation of acute bacterial and viral infections, fever with or without vomiting, manifestation caused by inflammatory bowel, fever, cramping, and pain, bloody stools, and malabsorption from diarrhea, fat and stools, bloating, and diarrhea. Abdominal pain, symptom of a number of gastrointestinal disorder, mechanical, inflammatory, ischemic, parietal, or somatic pain, and the peritoneum. Visceral pain is the organs themselves, and referred pain is felt in other areas. We'll talk about this when we have another audio review for how to assess abdominal pain. Biochemical mediators of inflammatory response, histamine, bradykinin. So this is abdominal pain is a critical component of assessing a patient with alterations in elimination, diarrhea, the GI tract, because being nauseous and vomiting can be many kinds of diseases, but to have pain, abdominal pain, is an abnormal finding which really has to be worked up. Just as a guide, the more severe the pain, the more severe the problem. GI bleeding, upper GI bleeding from the esophagus, stomach, duodenum, and then you can have frank red blood bleeding in emesis, dark, grainy digestive blood as coffee grounds. Lower GI bleeding from the jejunum, ileum, colon, and rectum, and treatment is blood products. So one of the questions that I frequently ask when I do this lecture in class is what is the mortality of a person who comes into the emergency room and has GI bleeding. So there are many studies to show this, but somewhere between 20 and 30% mortality just arriving in the emergency room with frank bleeding, whether it be coffee ground or bright red blood. So this is a medical emergency and should be treated like that when you see it. If you have patients come to your clinic, you should send them to the emergency room. So GI bleeding, hemaemesis is bloody vomiting, hemochromatosis is bloody stools, melena is black tarry stools, and occult bleeding not visible. When you do WIAC, right? Dysphagia is difficulty in swallowing. Types of mechanical dysphagia, obstruction of the esophagus, intrinsic, and then functional. Achalasia is de-innervation of the smooth muscle of the esophagus, and it's propensity for esophageal cancer. It can be caused by a parasite effect. Clinical manifestations, upper GI instruction, the discomfort at 2 to 4 seconds after swallowing. Lower esophageal, 10 to 15 seconds. All types of retrosternal pain, regurgitation, undigested food, unpleasant taste, weight loss, and vomiting. Treatment, eating slowly, smaller meals, taking fluids with meals, and sleeping with the head of bed elevated. Oral medications may be needed to formulate facilitate swallowing. Tube feeding, particularly after stroke, dilatation or surgical myotomy for lower esophageal sphincter problem, and people are trying botulism to treat this disorder. GERDs, a gastrointestinal reflux disease, becoming a more common disease. So acid and pepsin are two types of digestive enzymes of reflux from the stomach into the esophagus. And resting tone of the lower esophageal sphincter tends to be lower than the normal, or either transient relaxation or weakness of the sphincter. So it's just a matter of pressure. In addition to increased abdominal pressure, GERDs is vomiting, coughing, pending obesity and pregnancy. This is sort of what the ulcers look like when they appear. We'll look at some more of that pictures in a little bit. This is a hiatal hernia, which puts you at risk for this developing because the sphincter should be down here. The clinical manifestations: heartburn, acid regurgitation, chronic cough, laryngitis, asthma, and sinusitis. Chronic cough is, I think, one of the differentials that you do when people have a chronic cough, but I think it's important to consider it as GERD, but it's probably more than likely another cause of cough, but it's also important to consider it. You can have upper abdominal pain 1 hour after eating, evaluation by biopsy, dysplastic change of Barrett's esophagus. This is when the epithelium and squamous epithelium and epithelium change into this type of columnated looking epithelium. Treatment: proton pump inhibitors, most effective, histamine, type 2 receptors, and agonists, prokinetics, elevation head risk to reduce weight, stop smoking. Put the head up on wooden blocks or big blocks, not just putting the head of the bed up, because they'll fall off their pillow or slide down to the end of the bed. If the whole bed is elevated, then the head will be elevated regardless of where they are. Surgery and laparoscopic fundification, which is kind of a repair of the sphincter. Hiatal hernia is protrusion or herniation of the upper part of the stomach through the diaphragm into the thorax. Characteristic of sliding, the most common. Proximal stomach moves in the thoracic cavity. Paraesophageal is kind of also rolling hiatal hernia. Has greater curvature of the stomach. Is a secondary opening in the diaphragm. And a combination of both. And these are what they look like. A GE junction. This is what it looks like normally. There's a window in there so you can see it. And this is a type 1 and type 2 and 3 type hernia. So you can see that this should be down here, and part of the stomach is actually ascending up. It's this cause of this dysfunction in the sphincters and the motility of the stomach. Clinical symptoms: asymptomatic, heartburn, regurgitation. Many people don't. Treatment: for small, frequent meals, avoidance of recumbent position, avoidance of abdominals. Treatment: pyloric obstruction is the blocking narrowing opening between the stomach and duodenum. It's acquired or congenital. Clinical manifestations: epigastric pain, fullness, nausea, cessation is swishing, sloshing, splash, vomiting, prolonged. Gastric drainage is one of the preferred treatments. Intravenous fluids, electrolytes, proton pump inhibitors, histamine blockers, and surgery or stenting.